Great, thank you. Thank you. So it's just to say that in young children, it doesn't work. So this is a almost 4 years old girl. We did this Meteso technique, but for the elbow, and 5 years and 5 more months later, nothing changed. The Meteso technique is a cheaper technique, less invasive, and at least as effective as other techniques. And because Federico Canavese is an orthopedic surgeon, I think he's ideal to discuss this talk. And then the reason might be because the growth is really poor in the distal humerus. So if you take a male at the age of 4 years old, it will grow like 3 centimeters. By 6 years, 1.5 centimeters, according to this preached work. But still, it should change something. Okay, but it didn't. Then, if you look to other situations like lateral condyle fractures, you see that even using cannulated screws in very young children, there are no problems with growth. So it means that maybe this physis grows less than we think. But I found this case report that in a pre-adolescent boy, they use 8 plate and they obtain 6 degrees of correction by 1 year later. Okay, anyway, I did 5 patients with a mean age of about 4 years and a mean time of almost 4 years later, nothing changed. And you can see another case, 4 years and a half, and 4 years and a half later, same deformity. So the conclusion is that this hemiphyseodesis for distal humeral, at least in young children, is not effective. And if the child or the parents want a correction, the osteotomy is still the standard treatment. Okay.
So I think we can start discussing this paper. Good morning, everybody. I'm Federico Canavese from Lille, France. And I have a question for Francisco. I'm just wondering if the direction and the location of the screw may play a role. Rather than inserting the screw from the medial side, if you had put it towards the lateral side, maybe more vertical, and maybe giving a more tight purchase at the level of the distal humerus, will this may have changed something? I mean, rather than putting the screw from medial to lateral, doing it lateral to lateral, and with a screw that is more vertical and perpendicular to the growth plate.
Yes, but in the knee, the results doing vertically or oblique are the same, right? In the knee.
Yes, yeah. But I think that one issue that has to be taken into account is that in the distal humerus, the ossification is not coming from one secondary ossification center like in the knee. In the distal humerus, you have multiple ossification centers. The first one to appear is the capitellum, and then you have all the others that do appear at different stages. So probably this has to be taken into account, because at the level of the distal humerus, you have different areas growing and ossifying a different piece. Whereas at the level of the knee, you have one main growth plate which provide the growth at the level of the knee. And if you look at this, it's very similar to the distal radius. The distal radius is just one growth plate. You know what I mean? And with just one ossification center. Whereas in the elbow, the situation is different. You have multiple ossification centers appearing at different times. From age 1, the capitulum, up to age, let's say, around age 12, the lateral epicondyle. So this probably is also something that has to be taken into account, and maybe it's something that impact the outcome you are having with this technique.
And but the physis is one, no? Is just one physis?
Yes, but in the humerus, the physis does not ossify at the same speed, because the ossification, you first have the capitulum, then you have internal, the epitrochlea, medial epicondyle, and so on and so forth. Then you have the trochlea, and then you have the lateral epicondyle at the very end. So these stages of ossification are not one single process coming from one growth plate with just one ossification nucleus. The femur, you have the femur at birth that is completely cartilaginous. And then you have one ossific nucleus that appears in the middle of the physis. And then over time, this grows. But in the elbow is not this case. You have different secondary ossification centers.
This is a very interesting comment. Scott, what do you think about this?
You know, honestly, Paco, I never thought about it. I never thought of, even though the ossification centers occur at different times, I never thought that it would grow at different length. I think for me, it's a new thought.
Because also you discussed in your short communication that I have read about this topic, that some sort of similar technique were provided to prevent the fishtail deformity to get worse, mostly on the ulnar side. But if you think about the fishtail deformity comes because the trochlea is not growing, whereas all the other part of the elbow are growing, because probably the injury happens for fishtail deformities around age 7, 8, 9 years of age, when the trochlea is supposed to ossify the most.
Right. We discuss also this in the paper. No, it's interesting. And can I make a question? What do you think that in a lateral condyle fracture in a 2-year-old child, you put a screw and they don't have a deformity? The same reason, because of different ossification centers.
I think yes, probably this is something. And then the other parameter that should always be taken into account is how the growth occurs, in which direction, because you can have linear growth, longitudinal growth, like maybe it's in the knee, but then in the elbow, let's say at the level of the lateral condyle, because anatomically the distal humerus is wider and larger than the proximal one. So at this stage, you have probably less longitudinal growth than volumetric growth. So if the issue for the distal humerus is not growing in length, but growing in size, let's say medial to lateral and anterior to posterior, then maybe you understand why, if you put a screw on the lateral condyle, you don't address the frontal plane, while you may address mostly or somehow the volumetrical growth of this particular part of the distal humerus. And I think that all these studies are good, but are based on plain radiographs, and probably really to check how much the size of a distal growth plate of the humerus and the direction change. Probably MRI studies without hardware should be performed, because otherwise we don't have any clue about the cartilaginous part of the distal humerus. We see that there is a screw somehow going somewhere, but then all the cartilage is not seen on plain radiographs. So you don't really know how your screw has impacted this cartilage. You just know that your screw is in the ossific nucleus, but you cannot evaluate the effect on the cartilage itself, because you don't see it on plain radiographs. I mean, macroscopically, you see that your elbow didn't change, but you don't know if maybe the screw is too short or not placed in the good position, because you don't see the cartilage. You just see a line in between the distal humerus and the capitulum.
Nice comments. Scott, any other?
But Paco, I think there is a role for shutting down that growth plate if you're getting progressive varus. I think that still makes sense, right? If you have a young kid that has a progressive varus, shutting down that growth is actually a good idea. I think it just grows so slow. You know, Roger Cornwall has a case where it took 20 years for that distal humerus to remodel, and I think that's the problem. It's a very slow-growing physis, just like you showed in that chart.
Yeah, I agree. And also, if you look at the other papers that were published about the remodeling of the distal humerus in supracondylar fracture, for example, it's clear that the remodeling potential of the distal humerus is so small because the growth rate, because the amount of growth of the distal humerus compared to the proximal humerus or to the distal radius is very little. So also the remodeling capacity is limited.
So thank you very much, Federico. Federico is enormous pediatric orthopedic surgeon, and he did a lot of publications about pediatric upper limb trauma. So you can contact him anytime you want. Thank you, Federico.
Thank you very much. Goodbye.
Bye. Thank you, Federico. Thank you.